Okay, welcome everyone. My name is Dany Weisz. I'm a neonatologist at Sunnybrook, and I'm joined by my co-moderator, Dr. Poorva Deshpande, who's a neonatologist at Mount Sinai Hospital. And we're pleased to moderate the session today on a special session on the patent Ductus Arteriosus. This is the fourth day of the clinical cardiopulmonary physiology for the care of the sick newborn course. I know the past 3 days have been fantastic. I have no doubt today will be the same, and I thank everyone in the audience for taking the time to join us today. We do have a star-studded lineup with 4 fantastic speakers who have defined the field over the last 5 to 10 years. So let's just kick it off, and we'll get right to our first speaker, who does need very much introduction, but I will do my best. Dr. Patrick McNamara is presenting on PDA physiology in 2021. And Dr. McNamara is a professor of pediatrics and internal medicine at the Steed Family Children's Hospital at the University of Iowa. He is a internationally renowned expert on PDA, amongst other things hemodynamics related. And Dr. McNamara, please take it away.
Okay, thank you, Dany. That was a really well articulated introduction, and I hope our attendees have been enjoying the sessions. This is the first time we've held a conference in this manner, and I think it's gone pretty well. So I'm going to take as I oftentimes like to do, to take the 37,000 feet kind of panoramic view of the problem and try to set up the kind of session for the remaining talks, which I think will certainly provide a very good overview of our contemporary thinking and evidence for this particular problem. I have just one disclosure. So over the last 10 to 15 years, there's been a fairly obvious secular movement away from treatment of the ductus arteriosus, both in terms of medical and surgical therapy. The data on the right-hand side is from the Canadian Neonatal Network. And during the same interval period, there's been a growth in the approach to conservative therapy, which certainly has forced us to think very carefully in terms of who are the patients that we are most worried about. And you know, when I give this talk, I continue to be disappointed in that, 50 years, 60 years, how little have we advanced since the first reports that the ductus was a determinant of cardiorespiratory failure in a cohort of 6 infants in Australia. And even more concern is the fact that the pendulum has shifted fairly significantly, and in some respects to another extreme. And I think we in neonatology have been really, I would say, fall victim to major pendular shifts. And I think part of the reason for that, and we talked about this at the very beginning in the first lecture in terms of principles of physiology, we try to superficialize the problem. We try to make it black or white. We try to make it as easy as possible. Yet, when one thinks of cardiovascular physiology, it's not simple. It's complex. It's dynamic. It's determined by developmental factors and so forth. And in some centers, the ductus is not a problem. People don't think about it. They don't talk about it. They don't scan about it. Yet, do we have sufficient justification to move this far to the right? So when one looks at what is the justification for kind of moving away from empiric closure of the ductus arteriosus, the first is based on our data from spontaneous closure. This is Jan Milliton's natural history study conducted in Ireland, which, if you look at the graph on the left-hand side, in larger babies, up to 90% of PDAs may be closed by approximately day 20 of life. So in many patients, the PDA will close spontaneously without any form of medical or surgical therapy. However, if one looks at infants who are less than 750 grams, who represent the developmentally most immature and vulnerable patient population, one can see that a different pattern is noted. And the fundamental question that we need to ask is exposure of 50% of these patients under 750 grams to a median of 50 days an acceptable risk? The other factor that we actually have no idea is to what are the biological mechanisms that underpin closure. We assume that it's the process of natural PDA remodeling that occurs, leading to eventual closure. But an alternative explanation is in the face of progressive augmentation in pulmonary vascular resistance, leading to diminution of transductal flow. Does that create the biology that will allow closure to occur? In essence, are we sacrificing one problem, meaning PDA, for another problem, meaning pulmonary vascular disease? And we'll come back to that later on. The second and probably more relevant justification for a movement again away from universal approach to therapy is data from Bill Bennett's very well orchestrated meta-analysis. And the conclusions from the meta-analysis are the conclusions. PDA therapy leads to decreased ductal patency, but without any positive modulation of important short, intermediate, and long-term outcomes. So I'm going to take you back to last October at the NCE AAP meeting. I attended a panel and was asked this question. A 1-month-old preterm baby who was ventilator dependent, a cardiology echo revealed a moderate-sized PDA with a left to right shunt. Would I close this PDA? And my answer to the question is, I don't know. I don't have sufficient information to tell me that I'm actually dealing with a fundamental problem. So when we interrogate the literature, and I think the first part of this talk is, how good is our evidence? And I would sum it into the following questions. 1, did we actually study the problem? Did we actually study patients who physiologically had a shunt that was leading to dysregulation of pulmonary and systemic blood flow? Secondly, in the trials conducted, did we randomize patients to treatment versus no treatment? Thirdly, is the data from the meta-analysis contemporary? Is it relevant today? And finally, is the approach to evaluation of treatment efficacy reliable? So first, what about the definition of the problem? And not surprisingly, when one looks at this particular meta-analysis, looking actually at the criteria used to adjudicate hemodynamic significance, one can see that it was inconsistent. In many trials, we did not even have echocardiography as a criteria. And the vast majority of studies used a very loose subjective assessment that the ductus was problematic. We call it hemodynamically significant based on its just mere presence. So PDA assessment based on conventional methods in many programs is highly limited in the fact that it's reliant on a 2D assessment of PDA diameter, which is prone to operator, equipment, and location-dependent error. And the table on the right-hand side is a study we conducted and published about 3 years ago when we looked at echo markers of hemodynamic significance. And if you look at the correlation coefficient between different observers, you can actually see that PDA diameter and LAO ratio performed the worst, which is slightly concerning in that these are the measurements used in the vast majority of centers. In addition, if we look at the relationship between diameter, whether it's indexed to weight or LPS size, and the relationship between all of the following on the left, echocardiography indices that tell you that there may be flow disruption, both at a level of volume loading of the heart or systemic blood flow, you can see that the R-squared value demonstrates a very weak correlation. And this is not surprising, and we'll come back to this later on. When one thinks of flow, it is not just about the diameter of the vessel. There are many other modulators, including the length, the viscosity, and the pressure gradient. So diameter alone may not necessarily help you identify the right patients. Another reason for this is that the ductus geometrically comes in all sorts of different shapes and sizes, as you can see on the images in front of you. And why this is important, it comes down to assumptions. When we're measuring with echocardiography, PDA size or diameter, we make the assumption that in cross-section, at the presumed narrowest point, that the ductus is circular. The images on the right-hand side, which are some pathologic reconstructions of a series of PDAs that we kind of identified at autopsy, demonstrates that architecturally it comes in all sorts of different shapes and sizes. And why this is relevant is dependent on the imaging plane. You may either overestimate or underestimate the diameter, which if that's all you have, and for most neonatologists, that's all they see in the report, either a subjective or a unidimensional assessment of diameter, you may not necessarily appropriately evaluate the problem. The second question was, did we randomize patients to a true control group? And all across the board, you can see that apart from only 1 or 2 studies, more than 50% of patients in the control arm received some form of therapy. Even the recent Pda Tolerate trial, up to 63% of patients received therapy in the control arm. The next point is the data contemporary, and this is something we don't think enough about, which is, are the patients in the trials relevant to the patients we take care of in 2021? And when you actually think of the meta-analysis, the median year of publication was 1994, which is very different to what we do today. We have more tiny babies surviving. We have nitric oxide, we have better ventilators, a different approach to feeding, different use of steroids. And the concept, should trials expire, is something we really need to think of more carefully. And I would argue that most of these trials are not relevant to who we are interested in today. 2 additional considerations to think about. One is the one of equipoise. We assume that the patients in the trials are the patients we are interested in and the ones we look at on a day-to-day basis. This is a subgroup or post-hoc analysis of the Pda Tolerate trial, which demonstrates that up to 35% of the eligible patient population were not enrolled. And in Melissa's review of the eligible patient population, you can see that the non-enrolled babies were younger, smaller, thicker. Most interestingly, they were more likely to receive early medical therapy and actually had a superior outcome in terms of death or BPD than any of the groups in the trial itself. The final consideration is the consideration of physiologic efficacy. We translate data from trials of therapy based on the assumption that the therapy is doing what you're trying to achieve, elimination of the problem. This is a very small post hoc analysis of a Afif Al-Kafash study we conducted in Ireland. The primary trial showed no difference in terms of the outcome of death or BPD. However, as you can see, when one looks at in the intervention success group, although the numbers are small, the rate of the composite outcome in BPD was actually lowest in those patients in whom treatment was successful. So, to summarize, whilst our data clearly demonstrates that in randomized trials that PDA treatment universally may not be effective, as you can see, there are major limitations to the trials that we conducted to date. So I want to focus on one entity from a biologic perspective, probably one of the most controversial entities, BPD. And BPD as an entity itself has major challenges. We assume that it's a singular disease. We're starting to learn that actually BPD is probably a hybrid of kind of true lung disease, pulmonary vascular disease, pulmonary venous disease, secondary to left heart disease. But again, for what it's worth, it is an important entity that has been linked to PDA. Now, first, we must recognize that there are many, many biological contributors to BPD, which range from prenatal to genetic to postnatal factors. But from a biologic perspective itself, it does make sense that there may be some relevance, particularly when one thinks about the two most important modulators from a PDA perspective, the magnitude of the shunt and the duration of the shunt. And if you look at the image on the right-hand side, you can see two examples, normal flow in the pulmonary veins. Here on the right is an infant that has a torrential left to right shunt with very high systolic and diastolic flow. And this is something we lose sight of, which is the direct effect of high flow in vessels, particularly in the pulmonary veins. But in the face of chronic excessive overcirculation and increased delivery of hyperoxygenated blood to the pulmonary vascular bed, theoretically, we create a milieu that may lead to internal thickening, medial wall hypertrophy, and pulmonary artery hypertension. I think this is going to be probably the battleground and the best way in which we can adjudicate the impact of shunt management on the immature lung. So what evidence do we have of at least an association? Well, from the primate model, one can see quite clearly that in animals who were exposed to chronic PDA shunts leading to elevated QPQS, there was an impairment in lung compliance that was sustained, unlike the animals who were randomized to medical therapy and had PDA closure. The most interesting part of Don McKernan's work is that when they looked at the baboons at 36 weeks gestation, there was impairment in alveologenesis and an increased risk of abnormal lung development. From our moderator, Dany Weisz, when he conducted his master's in Toronto, looking at a large cohort of infants who underwent surgical ligation versus a comparator group who underwent medical therapy, one can see that the ligation group tended to have a more prolonged respiratory course of increased severity, but as early as the first few days of life, they seem to separate themselves in terms of their lung disease, suggesting that perhaps the worst babies may actually be identifiable early in the first week of life. Some work from Ron Kleiman's group, and you'll probably hear this again today, again adds to the argument that it's not just about mere presence of the ductus, but also magnitude of the shunt, duration of exposure. Here you can see that in infants who were ventilated more than 10 days, who had an increasing exposure to shunt, there was an increase in the incidence of BPD, particularly stage 2-3 BPD. Some work from Fernando Scena's group in Italy, when they looked at actually using a PDA score, you can see that in infants who had, again, the most prolonged shunts, ultimately reading surgical ligation, were those infants who were at a higher risk of BPD or mortality. We recently published, this is Danielle Rios' work from the Iowa cohort, and actually in Toronto cohort, demonstrating again that more comprehensive assessment beyond size, looking at PDA score, and in this study here also the presence of a large atrial level shunt, again appeared to identify a population at increased risk of death or BPD, in addition to traditional risk factors such as gestational age. So what about moving to a non-intervention policy? And again, we're starting to see data emerging that perhaps that the pendulum shifting too far to the right may identify some problems. And this is from Gabriel Altet's group in Montreal, where they compared two centers, one in whom they evolved to a conservative or non-interventional approach to PDA. And what one can see is that in this particular group here, the incidence of the composite outcome of death or BPD increased by 31%, but in the smallest infants, infants under 26 weeks gestation, suggesting two things, that this may be a problem of the tiny babies, but perhaps moving too far to the right may actually lead to harm. This finding was also replicated kind of by the Miami group, again, recently, in a second epoch in which they evolved to conservative therapy, an increased risk of death or BPD. Now, what scares me the most about this is very rare in neonatology. We see things get worse over time. normally practice get better, interventions get better, we ventilate babies, we improve our outcomes. But to see a deterioration in major neonatal morbidities is somewhat of a concern. So I mentioned pulmonary hypertension. I think again, is going to be increasingly important for us to think about. This is some work from 1953 suggesting that in patients, and these are older adults exposed to PDA, that there's an increased intrinsic risk of pulmonary hypertension. And now that we're evolving to cath closure as a more permanent and standardized way of closing PDA, we're starting to get some insights that chronic exposure to PDA shunt may be increasing the risk of pulmonary vascular disease. And some work from Shyam Satyanandan's group, who have performed the largest number of cath closures, revealed very nicely two things. One, infants who had the most prolonged exposure to shunt had a much longer recovery time after PDA closure. But even more interestingly, when they looked at the incidence or the rate of elevated pulmonary vascular resistance, it was highest in the group that had the most prolonged shunt exposure, suggesting that there may be a problem here that we just don't know enough about at this point in time. So I want to take you now to Iowa, which I've moved here in 2018 and have the privilege to lead the most remarkable program. And when I got to Iowa, we have incredible survival rate for infants born at the limits of viability. And one of the questions that we asked was, can we further enhance outcomes, and in particular, outcomes such as intraventricular hemorrhage and so forth? So currently the AAP suggests that you should think about the PDA at day 7 of life. And if one starts to think about the ductus only on day 7 of life, other outcomes such as intraventricular hemorrhage, hypotension, pulmonary hemorrhage, which have been associated with the presence of PDA shunts, one is not likely to modulate these important outcomes. One is left to looking at entities such as NEC or BPD. So in thinking about how do we better manage the physiology of these shunts, and I showed you this slide on Monday, it's important to recognize firstly that the shunt itself is not just determined by the diameter of the vessel, but it's also determined by pressure gradient, viscosity, length of the vessel. There are many assumptions regarding flow that are important, but these may be not easily transferable because the ductus is not necessarily a cylindrical vessel consistently. But again, important to remember that these factors may influence the ambient physiology. What evidence do we have for conservative therapy interventions? And we don't have a lot of direct evidence. If we think of carbon dioxide, elevated CO2 is going to increase pulmonary vasoconstriction, going to cause pulmonary systemic vasodilation. Oxygen will have the opposite effect. A little bit of evidence that PEEP may have a vasoconstricting effect on the lung. And for viscosity, we really have very little evidence. There's one recent publication by Sébastien Jouaz suggesting that higher hemoglobin in the first week of life might be associated with an increased risk of spontaneous closure. This biology does make sense, and certainly we use this as part of our practice to titrate and limit shunt volume in addition to medical therapy. But again, as you can see, there's not a lot of evidence to directly support this in the context of PDA shunt. Our approach is very much based on comprehensive assessment, based on the recognition that there are some shunts in which you do not want to close the ductus because there's heart dysfunction, there's pulmonary hypertension. We're most interested in those patients who have high volume shunts, leading to dysregulation of pulmonary and systemic blood flow. What's most interesting about the markers is when you actually look at the first week of life, and this is some data from a study we conducted between Ireland and Canada. And what you can see is that in the first 7 days of life, there is a cohort of infants in whom the PDA will close spontaneously, who have very little disruption in any of these physiologic indices of shunt volume. Unlike infants who have persistent large PDAs, as early as the first 24 to 48 hours, there's an increase in pulmonary vein flow, left ventricular output, and abnormalities to systemic Dopplers. Here at the University of Iowa, we have a comprehensive program. We have 5 faculty. We have kind of a lot of echo equipment. And recognizing this physiologic disruption, we wanted to look at what is the impact of introducing an early targeted screening program. And based on a standardized assessment that's performed somewhere between 12 and 24 hours mostly, we provide physiology-specific care. So if there's heart dysfunction, we will treat that with dobutamine. If there's pulmonary hypertension, we will low-dose nitric oxide. If there are moderate to large PDA shunts based on a comprehensive score, the babies will receive Tylenol for 3 days, followed by a repeat echo, and potentially extending that to 7 days. The markers on the right are what we use to adjudicate hemodynamic significance. And this is the PDA score that we use that was published in our JACE paper early this year. So this is preliminary data. And again, I don't want anyone to take this away and start making radical changes to their practice. We will be submitting this to PAS this year and hopefully writing the paper up at the beginning of next year. But this is the preliminary data. And it's interesting. It's interesting from the perspective it's not randomized. But if one looks at the 7 years prior to the program compared to the 3 years after the program, one can see that during that intervening periods, we've had a doubling of the eligible patient population that are between 22 and 23 weeks gestation, suggesting we've got much higher risk of sicker, more vulnerable patients. But despite this, the rate of death or severe IVH, severe IVH itself, necrotizing enterocolitis, have fallen fairly substantially. And this is in a program that already had exceptional outcomes for these patients. We don't yet have figured out the rate comparison for chronic pulmonary hypertension because screening was not as good in the first epoch. But our rate of severe chronic pulmonary hypertension is less than 5%, which is interesting compared to centers that use a very conservative approach to the PDA that have rates as high as 30 to 45% and do not have as many surviving tiny babies. So at least this is hypothesis generating data. So I'm going to stop at this point, and what I want you to take away with this, that the PDA is something that you need to think about. There certainly is evidence that is associated with morbidity. However, an imprecise and indiscriminatory approach based on trial evidence to date has not been demonstrated to be beneficial. There is some preliminary evidence that early targeted therapy may be helpful in reducing things like pulmonary hemorrhage, late need for treatment, and perhaps IVH and NEC. I believe that enhanced diagnostic precision based on comprehensive appraisal of hemodynamics best will characterize the population at risk. So I'm going to stop, and I look forward to questions later on. Thank you.
Thank you, Patrick, for that fascinating talk on the subject, which doesn't stop fascinating us. Before I introduce our next speaker, I would just like to remind the attendees that there will be a Q&A section at the end, and to please post in your questions in the Q&A chat box. And so over to our next speaker. Our next speaker is Dr. Souvik Mitra, who is a neonatologist and an associate professor at Dalhousie University in Halifax. And his research interests are therapeutic treatment of PDA. Over to you, Souvik.
Thanks, Poorva, and thanks, Patrick, for setting the stage. Probably there will be some repetition of some of the issues that you have highlighted, because that's important to bring up again. I have no conflicts of interest to disclose. So before I move on into the details of PDA therapeutics, we need to take a moment to acknowledge this big elephant in the room, that no matter how much one has worked on the PDA, we still need to agree that there's still a lot to learn about when to treat, whether to treat it at all, and what to use. because the small little blood vessel that is essential in fetal life still remains an enigma for neonatologists across the world. In late preterm and term infants, it is not a problem, closes off in the first few days. But in extremely preterm infants, if it persists, it can create a lot of problems, as Patrick alluded to. It can increase blood flow to the lungs, contributing to pulmonary hemorrhage and subsequently BPD. It can alter the blood flow to the brain, thereby possibly contributing to IVH and PVL. And it can steal away blood from the gut and the kidneys, thereby contributing to neck and renal failure. And these are not problems that have been recently identified. I mean, these associations people knew about since the time physicians have been taking care of preterm babies. So much so that this conference back in 1977 was purely dedicated to the Ductus Arteriosus. And this is where the first ever randomized trial on trying to eliminate the problem, that is the PDA shunt, was first presented. It was a small trial where they randomized very low birth weight infants with a symptomatic PDA at a week of age to surgical ligation versus medical management. And they found that infants who had an early ligation had better respiratory and GI outcomes. But the problem was early ligation, which for a lot of reasons we do not like. Now, in the same conference, there was a lot of talk about patency of the ductus and how prostaglandins play a role. And there was some preliminary data presented on how prostaglandin inhibitors, such as indomethacin, can substantially reduce the PDA diameter in fetal lambs. Now, I'll draw your attention to the dosage here of 0.2 to 0.4 milligrams per kilo, because unfortunately, this dosage still persists in today's world. Now, what have we done since then? So, since then, when we found that there could be a non-surgical way of closing the duct, we probably got a bit too excited and spent the next 40 years and more than 80 randomized trials trying to figure out the best non-surgical way to close the duct, without really replicating the question, what happens when a PDA shunt is eliminated? So here we are now in 2021, left with no large randomized trial evidence that definitively proves PDA causes poor outcomes. And therefore, this is unfortunately how we end up appraising the PDA evidence in today's world. But in the meantime, there has been a number of well-conducted, well-thought-out, large observational studies such as these. And again, Patrick has alluded to a couple of them already, that really makes us think that we cannot really ignore this association. And this cohort study from the INEO group has really been eye-opening. So this was a very large cohort study that included more than 39,000 extremely preterm infants from 139 NICUs across 6 countries, where they found, not surprisingly, that the Pda treatment rate was widely variable, ranging from 13 to 77%. Interestingly, what they found was that the observed to expected PDA treatment ratio had a U-shaped relationship with their primary outcome, that is death or severe neurologic injury. And the same relation was also observed with the components of the primary outcome, as well as necrotizing enterocolitis. So what that means in simple terms is that centers who have a very high rate of PDA treatment, or the ones who are extremely conservative, had bad outcomes. And there is a sweet spot somewhere in the middle, probably those who have a more thoughtful approach to PDA management. So most of the neonatologists do acknowledge that in extremely preterm infants, not treating a PDA is probably not a great idea. But many of us are still conflicted whether to treat it early or wait on it and deal with it only when it continues to cause problems. And that's because the decision to treat is always this balance between anticipated benefits of treatment and the potential risks. And unfortunately, the therapeutic modalities that we can offer right now as a primary therapy are cyclooxygenase inhibitors. Now, we already know that prostaglandins help to keep the PDA open, and therefore cyclooxygenase inhibitors such as indomethacin and ibuprofen, and more recently acetaminophen, which also can act on the peroxidase enzyme, can help to downregulate prostaglandins and therefore help to close this open PDA. But these are not good drugs for preterm babies. We know indomethacin and ibuprofen can adversely affect the gut and the kidneys. Indomethacin, in addition, can alter platelet function and impair cerebral blood flow, whereas acetaminophen appears to be at least safer in the shorter term, but its effect on long-term neurodevelopment is still unknown. And that's probably the reason why a lot of physicians would want to adopt this early wait and watch approach. And as this study by Sembrova on the natural history of spontaneous PDA closure suggests, that this early wait and watch approach may not be a bad idea in some of the older preterm infants, such as those who are more than 30 weeks, where about half of them would close off their PDAs by a week of age. And even in babies between 26 and 28 weeks of gestation, may be reasonable, as about half would close off the PDAs, but about a couple of weeks of age. But in the micropreemies born less than 26 weeks of gestation, it appears that they remain exposed to this PDA shunt for days on end, with only 50% closing their PDAs by about 2.5 months of age. So the question is that by keeping them exposed to a large shunt, are we causing some irreversible damage to these vulnerable micropreemies? Which raises a very pertinent question: does early medical treatment help? And if yes, then in whom? So to explore that a little further, we recently conducted a Cochrane review of randomized trials, where we identified 14 randomized trials, 7 comparing early treatment within 7 days to expectant management, and 7 comparing very early treatment within 3 days to expectant management. In summary, we found that neither of the approaches had any effect on any of the clinically important outcomes, such as death, BPD, or PDA ligation. But on the other hand, we found that both early and very early treatment significantly increased the risk of NSAID exposure in these preterm infants, which is definitely not a good thing. So what about treatment between 7 and 14 days? 2 recent randomized trials, one a multi-center trial from the US known as the PDA Tolerate trial, and the other a non-inferiority trial from South Korea, both failed to demonstrate a benefit of treatment between 7 and 14 days compared to conservative management. So overall, there is no randomized trial evidence till date that shows benefit of treatment initiated within the first 2 weeks of age. So now you, as a clinician who wants to practice evidence-based medicine, takes it back to your own unit, and now you have a preterm infant, 25 weeks of gestation at birth, now 4 days of age, on high ventilatory settings, high oxygen needs. You do an echo, and you find a large PDA with severely dilated left side of the heart. So as per evidence, you shouldn't be treating this kid. And a lot of centers did follow this evidence. So let's see what happened in the real world. And again, Patrick has alluded to some of this already, but I'll again go through this. So this is the Canadian experience. A recent study from 2 comparable centers in Montreal, where one center continued their usual practice of medical treatment and ligation, while the other, based on the evidence that I just showed, changed to a non-intervention policy. Interestingly, in the older preterm infants, that is, those born between 26 and 29 weeks of gestation, there were no difference in outcomes in either of the centers in either epoch. But in the center that stopped treating PDAs, in the micropreemies, there was a 31% increase in the incidence of death or BPD, while none of that happened in the center that continued their older practice. Now let's see what happened in the US. Again, a very similar study published in the same week, actually, in Journal of Pediatrics, this time from Jackson Memorial Medical Center in Florida, where they looked at 2 epochs. The first, where they used to diagnose and treat babies early, and then they moved to a more conservative management approach. The demographic profile of both the cohorts were fairly similar, with a mean gestation of around 26 weeks. And again, very similar to the Canadian experience, when they moved to a conservative approach, their rates of BPD and BPD or death significantly got worse, which raises a lot of questions about the existing trials. The first is that the majority of the trials have not really focused on the infants who are at the highest risk of PD attributable morbidity. The second is the issue of imprecise trial definitions of PDA, and we've already had some wonderful insights on that from Patrick, that most of the trial definitions have been based on one or two poorly validated cutoffs, such as PDA size and LAO ratio. And I'm afraid some of the ongoing large trials also suffer from this exact problem, and therefore they may not be able to pick up a signal amidst all the noise created by this diagnostic imprecision. The third is we need to understand that all these trials of early therapy have essentially tested effectiveness of giving treatment, but haven't really tested the effectiveness of elimination of the shunt, which is the actual problem. Therefore, we really do not have any idea on whether early effective treatment of a significant PDA shunt in a micropreemie improve outcomes. So until we have that evidence as a clinician, should you stop treating early? Well, for older preterm infants, in most cases, your answer could be yes, but this might not be a good idea in micropreemies, especially those who are symptomatic with a moderate to severe PDA shunt, until there is definite randomized trial evidence of no harm. So now that some of you have decided to go ahead and treat, the next big question is what to use. And this is another big can of worms with so many Cochrane reviews and studies on this topic. So let's go back to the history again. So as I said, that we started off with indomethacin, with the first randomized trials done as early as in the 1980s. And since then, there have been a large number of trials with indomethacin, with this remaining the gold standard for treatment. But one thing hadn't changed, that fetal lamb dosing, which tells us that we probably should have done a bit more work on this. But also we know that the preemie guts and kidneys are not really fond of this dosing. So people really were looking for another option. And I must say that Canada has had an important role in the advent of ibuprofen in the treatment of PDA, with the earliest animal studies being done right here at the Hospital for Sick Children back in '79. And then a few years later, the first phase 1 trial on the use of ibuprofen was done in Montreal, where the investigators empirically chose a dose of 10 milligrams per kilo within 3 hours of life, followed by 2 doses of 5 per kilo at 24 and 48 hours. Now, all of you would recognize this dosing because in the next 25 years, this dosing hasn't changed, which really begs the question that have we done enough in finding out the right dosage in the right population? So we looked into this a little bit further. So if you look at the Cochrane reviews of ibuprofen, the primary failure rate sits at a fairly impressive rate of 25%, whereas in the real world, from a number of Canadian data, we find that the primary failure rate of ibuprofen is way higher, over 40%. But also, if you look at the trials, the median age of start of treatment in these trials was around 3 days. But now with increasing adoption of conservative management, we've pushed our start of treatment more towards the end of the first week. So therefore, we might be extrapolating this information from the randomized trials to a completely different population with different metabolism and dosage needs. So to explore this a little bit more systematically, we conducted a network meta-analysis a few years back, where we looked at all the different treatment options that have been used in randomized trials. That also includes the higher doses of ibuprofen. And we found that indeed, high-dose ibuprofen, especially oral dosing, was far better in closing a PDA compared to the more traditional dosage of standard dose intravenous ibuprofen. Now, was this merely a coincidence, a statistical fallacy, or is there some physiologic basis to it? In fact, there is, because there have been some pharmacokinetic studies that has shown that to achieve therapeutic concentrations of ibuprofen, regardless of your gestation age, you might need increasing doses with increasing postnatal age. And this randomized dose finding study that was conducted back in 2005 also explicitly shows that in infants who are slightly older, born between 27 and 29 weeks of gestation, the estimated minimum effective dose regimen was 10.55 milligrams per kilo, which was the standard dosage, and that had a probability of success of 77%. If you use a slightly higher dose of 15, 7.5, 7.5, your probability of success is slightly higher at 88%. But when you look at the extremely preterm infants, less than 27 weeks, the success for even the higher doses was only 55%. And for the standard doses, it's as low as 30%, which probably explains why standard dose ibuprofen never works in extremely preterm infants. The next question is about oral ibuprofen. Is it really better than intravenous? We don't have a lot of evidence, but there is some baseline work done by Barzilai as published back in 2012, where they looked at the pharmacokinetics of oral ibuprofen and compared that with the data by the Hurt publication and demonstrated that the area under the curve after giving oral ibuprofen is significantly higher, as following oral ibuprofen, you might maintain a plateau for a longer period of time compared to intravenous ibuprofen, which suggests that if possible, oral ibuprofen might be more effective than intravenous. So based on this, we at our own center back in 2017 changed from a standard dose intravenous ibuprofen regimen to a high dose regimen with provision of oral therapy whenever the baby was enterally feeding. And over the next 2 years, we have demonstrated a 21% absolute reduction in Pda ligation without a demonstrable difference in adverse effects such as oliguria or neck. But when we asked our Canadian colleagues and also colleagues in the US what would be their first choice for therapy, still majority would prefer to use the least effective option of standard dose intravenous ibuprofen, which tells us that we still need to do a lot of work to establish the safety of the higher doses in the smallest and sickest population. So what about acetaminophen? Now, acetaminophen for PDA closure had a serendipitous discovery by our colleagues in Israel who were using a dose of 15 per kilo every 6 hours orally for 7 days for a completely unrelated reason, and started to find that the ducts in preterm infants were closing. And that subsequently generated a lot of interest, led to a lot of randomized trials, but one thing never changed: the dosage. So what we know so far is that acetaminophen is probably equal in efficacy to ibuprofen in closing the duct, but has a much better safety profile with much lower GI bleeds. And the recent availability of the intravenous formulation does present an attractive option. But 2 recent randomized trials have slightly dampened our spirits, as both have demonstrated that intravenous acetaminophen might be far worse in closing a PDA in very low birth weight infants compared to both indomethacin and standard dose ibuprofen, which again raises the question that are we using the right dose of acetaminophen in the right population? And this very recent study by, which is an ancillary study of the Pre-Para-S randomized trial, makes this point very clear. So they used a loading dose of 20 per kilo, followed by a maintenance of 7.5 every 6 hours for 4 days. And they found that the PDA closure was great in older preterm infants, 31 weeks or older. But as you move down the gestation, 27 weeks and lower, the efficacy of acetaminophen significantly worsened. So to conclude, what I would like to say is that what we really need is timely and effective treatment of the PDA in the right population. Regarding timeliness, what we know from trials is that early treatment anytime before the first week is unlikely to benefit preterm infants, especially older preterm infants. But we do not know whether we can extrapolate this information to the micropreemies. Regarding the choice of treatment, it appears that higher doses of ibuprofen could give you a bigger bang for your buck compared to the more traditional standard doses of ibuprofen. But still, that does not guarantee shunt elimination, and we need a lot more work on finding out the optimal dosage. And finally, treatment in any form should be directed at the right population. And it appears that extremely low gestation age infants, such as those born less than 26 or 27 weeks of gestation, with precise echo markers of a significant shunt volume, with or without clinical signs, might benefit most from early effective therapy. And we need to establish that through a large randomized trial, ensuring diagnostic precision. Thank you.
Thank you, Shovik. Thank you very much for another fantastic talk on trying to navigate the myriad of options and scenarios for which to decide who and who not to treat. Obviously, lots of work still to do, and amongst the micropreemies, which I think most of us struggle with this decision, obviously not a whole lot of clarity at the moment, but I know your work coming up is hopefully going to shed some light on that. So thank you very much. I'm very pleased to introduce our third speaker of the special symposium on patent ductus arteriosus. And that speaker is Dr. Adrian Bischoff. And she is a neonatologist and expert in neonatal hemodynamics and targeted neonatal echocardiography. She's at the Steve Family Children's Hospital at the University of Iowa. And she's going to be discussing transcatheter device closure for PDA.
Thank you for the organizers for the opportunity to present today. I will be speaking about transcatheter device closure, including procedural success, postoperative physiology, and outcomes. Over the past few years, there's been a shift towards less surgical PDA ligations due to a more conservative approach in regards to PDA management, as well as the invasive risks related. On the left from the Memphis group, the number of percutaneous PDA closure has actually superseded what was previously done. Advancements in the technique, including the possibility of a venous retrograde approach, the use of newer devices appropriate for the preterm PDA morphology, and decreased fluoroscopy time with increased experience, have allowed this technique to be applied in progressively smaller and younger patients. Last year, we published a meta-analysis to describe the secular changes in practice and the procedural success in small babies. Out of nearly 400 patients included, over 95% of the procedures were considered successful. The graph on the right depicts that the probability of technical failure is inversely related to the age at the time of the procedure. Similarly, in this graph, you can see the trend over time according to year of publication from these studies. There has been an increase in the probability of technical success over time, going from less than 90% in the mid-2000s up to 98% in recent years. What's interesting is that this increase in success has also been accompanied by a trend towards the procedure being performed in smaller patients, which reflects the learning curve and professional feelings more confident and comfortable performing this technique in smaller babies. In this meta-analysis, the overall incidence of adverse events was 27%, with less than 10% of them being considered major adverse events. Interestingly, these adverse events were a lot more common in patients that are less than 800 grams at the time of the procedure. Another important aspect relates to the physiology of post-closure and the risk for cardiorespiratory instability. What is traditionally called post-ligation cardiac syndrome is a disease characterized by LV failure due to a high afterload state. The full spectrum of this condition includes cardiovascular instability, which is characterized by systolic hypotension with or without the need for inotropic support, plus respiratory instability, whether due to ventilation with or without oxygenation impairment. Although the transcatheter closure is less invasive than open surgery and there's potential for less inflammation, the changes in loading condition are exactly the same, and therefore we have adapted the name of this condition to post-closure cardiorespiratory instability. In the presence of a significant left-to-right PDA shunt, there's pulmonary overcirculation, and the LV is exposed to a relatively low afterload since the PDA is connected to a low-resistance circuit of the pulmonary vasculature. Once the PDA is suddenly closed, significant changes in loading conditions happen, such that there is a decrease in left heart preload, but also a significant increase in LV afterload, since now the LV is only exposed to the systemic vascular resistance. And these changes will eventually lead to a lower left ventricular output. This is an example of a preterm infant with an apical 4-chamber view showing a very dilated left heart secondary to PDA shunt. And 1 hour after the procedure, you can see that there's less volume loading and reduced LV systolic function. The immediate cardiovascular changes after PDA closure include an increase in diastolic blood pressure, which reflects the loss of the systemic steal from the PDA, with some concomitant increase in both systolic and the mean blood pressure. What you see on the right is data from patients undergoing percutaneous closure from our group, where the diastolic blood pressure rises immediately after cath and continues to rise over the next 24 hours. In infants who go on to develop post-closure cardiovascular instability, the typical course is that after an initial period of stability, with higher blood pressure compared to the baseline, there is a progressive decline, particularly in the systolic blood pressure. What's important is that the mean blood pressure remains relatively stable because the diastolic is either normal or high, which is why it's important for clinicians at the bedside to pay attention to all of the components of the arterial blood pressure. If this window goes unrecognized, which is typically during the next 6 to 12 hours after the procedure, disease progression is characterized by a subsequent decrease in all of the components of systolic, diastolic, and mean blood pressure. I always like to highlight that it's not any type of hypotension that fits the phenotype for post-closure cardiorespiratory instability. Specifically, early hypotension in the first 1 to 3 hours and predominant diastolic hypotension are not part of the spectrum of this disease. And if this is the primary pattern that is seen in the baby, then other causes need to be taken into consideration. So how do the changes in loading conditions affect the LV? The majority of the infants fall into the flat part of the Frank-Starling curve, where they go from a volume-loaded left heart to a condition of normal loading. In infants that have relative hypovolemia before PDA closure, whether because they had significant fluid restriction or they were being treated with a lot of diuretics, the changes in preload would cause an immediate decompensation after PDA closure, which is not what we typically see. On the other hand, the effect of afterload on heart function depends on sustained exposure, leading to a low cardiac output state, particularly in infants with more vulnerable and immature myocardiums. And that explains why the clinical manifestations that are seen as part of the post-ligation cardiac syndrome spectrum happen 6 to 12 hours after PDA closure. We recently did a study looking at advanced echo parameters of LV function prior and after to percutaneous PDA closure in premature infants. We looked at 30 babies who were less than 2 kilos at the time of the procedure, and we had 100% of technical success and 26% of exclusively minor adverse events. Our babies here at Iowa were on average a month old and just over 1 kilogram at the time that they got their PDA closed. Here on the left, you have graphs from previous studies in surgical closure, where you can see that the time of increase in SVR coincides with the time of worse LV systolic function, as assessed by strain analysis, as well as the timing for clinical deterioration. Similar to other studies in surgical ligation, our babies who underwent percutaneous closure had similar decrease in echocardiographic markers of left heart volume loading, LV systolic, and diastolic function. Moving on to the respiratory impact of PDA closure, the cessation of the left to right shunt is accompanied by an immediate improvement in lung compliance, which is clearly seen in these chest radiographs, but also on the ventilatory parameters, as you can see in this study here on the bottom. The respiratory instability is the second part of the spectrum of PLCS, and the likely mechanism is related to diastolic impairment with secondary increase in left atrial pressure, pulmonary venous hypertension, and secondary pulmonary edema. What we have noticed in the patients after percutaneous PDA closure is that the respiratory phenotype of PLCS is much more common and prominent than the traditional cardiovascular instability with hypotension or need for inotropes. Here is an example of one of the patients in our cohort. Prior to the procedure, the patient was on conventional mechanical ventilation in 35% of oxygen with very hazy and congested lung fields. Immediately after PDA closure, there was substantial improvement in compliance and the lung fields are much clearer. But over the subsequent 12 hours, the patient developed progressive pulmonary edema with both oxygenation and ventilation failure, requiring escalation in the mode of support to high-frequency ventilation. You can see the outcomes from our study in this table, where less than 15% of our patients developed true cardiovascular instability, but 40% had oxygenation failure, which brings the composite outcome to approximately 50% of the patients. In this graph, we separated the patients according to the development of the composite outcome, and you can observe in the darker gray bars that there was a significant increase in respiratory severity score, particularly after 6 to 12 hours following PDA closure, which coincides with the time frame that had been previously described in surgically ligated patients. We were interested in what are the risk factors for developing PLCS, and both lower weight at the time of the procedure, as well as postnatal age, are the main predictors. This graph is particularly interesting because it shows that the risk of PLCS in surgically ligated patients goes from as high as 50 to 60% if it's performed in the first week of life, and drops to less than 10% if it's performed after 30 days. This is an important consideration when looking at the various studies in the literature where post-procedural instability needs to be assessed in the context of a baseline risk. Describing, for example, a low incidence of PLCS in patients that are about 1.5 kilos, more than 30 days at the time of the procedure, is not particularly surprising based on what we know about their baseline risk. In the original surgical ligation studies, left ventricular output at 1 hour correlated with left ventricular output at 8 hours and was associated with low systolic arterial pressure and the need for inotropic agents. And this provided the groundwork for the use of early prophylactic Mirinone in infants with low LVO after PDA ligation. So based on the findings on these studies, a left ventricular output less than 200 in the 1 hour post-PDA ligation echo was an indication to start Mirinone prophylaxis in the hopes of preventing post-ligation cardiac syndrome. This was a follow-up EPOC study which showed a decrease in the need for postoperative inotropic support and a drop in the incidence of PLCS from 44% to 11% after the institution of a protocol using targeted Mirinone prophylaxis. Since Mirinone has vasodilator, inotropic, and lusitropic properties, it is a biologically appealing agent for a disease that is characterized by increased afterload, impaired LV performance, and diastolic dysfunction. In our cohort of percutaneous PDA closure, although it was not statistically significant, the babies who developed instability were a bit smaller and had worse lung disease at baseline. Importantly, our study was done extrapolating the use of the early targeted mirinone prophylaxis approach that we used in surgical patients. So what you can see is that we had a very high use of mirinone prophylaxis for the overall cohort, with no differences between the groups. And this is an important caveat because we can't determine what would be the true incidence of instability, including hypotension and need for inotrope, if this was an untreated population. When we looked at several relatively standard echo parameters, left ventricular output at 1 hour continued to be associated with the development of instability in this population, which again I highlight was a treated population with a high use of mirinone prophylaxis. Similar to our study that looked at a population treated with mirinone, Ting and his colleagues found that a pre-ligation isovolumic relaxation time, which is a marker of both left heart volume loading as well as LV diastolic function, was associated with a higher risk for respiratory instability. Although our study didn't corroborate this finding, there are some questions left regarding the risk and the therapies that are needed to prevent or minimize this type of condition and complication. We recently published a study looking at some other parameters in this population, which may provide some further insights in this topic. In a group of 35 patients less than 2 kilos who underwent percutaneous PDA closure, we found that after closure, there was a drop in preload, an increase in arterial elastance, and an increase in end-systolic elastance. We also used advanced speckle tracking echo to assess myocardial energetics, which you can see an example here in the pressure strain loop. We demonstrated that longitudinal strain, myocardial work, and myocardial efficiency decreased after PDA closure as well. Looking at these markers for the association with post-closure cardiorespiratory instability, we again found that younger age and PMA at intervention were associated, but also a lower baseline preload and a higher end systolic elastance. In the 1 hour post-TN echo, babies who developed instability had higher arterial elastance, a trend towards higher end systolic elastance, and lower ventricular arterial coupling. Another interesting finding was that after PDA closure in this cohort, one would expect that the significant increase in afterload and in arterial elastance would increase the arterial blood pressure. However, what we saw instead was that the magnitude of change in blood pressure was likely somewhat offset by the drop in preload. Why could this be relevant? Similar to aging adults that have heart failure and preserved ejection fraction, preterm infants have a higher baseline end systolic elastance, which reflects both the active and the passive muscle properties. The different slopes of end systolic elastance have a differential impact on how changes in loading conditions affect stroke volume, stroke work, and blood pressure. For example, this figure shows a change in preload for 2 different slopes of end systolic elastance. In the steeper slope, which is on the right, with higher end systolic elastance, there are bigger changes in pressure, even with small loading perturbations, at the expense of larger changes in stroke work. In this other example, where we manipulate arterial elastance for the same preload with different degrees of end systolic elastance, on the graph on the right that has higher end systolic elastance, you can see that the isolated increase in afterload produces a much more dramatic increase in blood pressure in the stiff system, with a less pronounced change in stroke volume. What that means is that the patient with higher end systolic elastance requires higher myocardial work and higher myocardial oxygen demand to achieve the same net volume of transfer of blood into the vascular system. How does this translate to our findings? Our babies immediately after PDA closure had a relatively unchanged blood pressure in the face of a decrease in stroke volume. This is important because the recognition of significant physiological changes in coupling, myocardial work, and LV performance can happen despite a relative stability of vital signs immediately after PDA closure. And these changes are extremely important may play a role in the risk of these patients developing cardiorespiratory instability. In other words, the intrinsic myocardial properties that relate to diastolic function or ventricular stiffening can provide the basis for a higher risk of ventriculo-arterial uncoupling, decreased ventricular efficiency with higher myocardial oxygen consumption, and an increased vulnerability to changes in loading conditions. I wanted to finish off on a less theoretical note with a practical resource in the management of these patients after PDA closure, based on the things that we've learned and the expected physiology. So as a recap, in patients who develop early or diastolic hypotension, this is not the typical spectrum of PLCS, and other causes need to be considered and addressed. In patients that have systolic hypotension or signs of low cardiac output state, treatment should focus on inotropic support, while patients with systemic hypertension, particularly those with respiratory symptoms, adjusting the Miranon dosage may be one of the key things. For patients who develop respiratory symptoms, despite Miranon prophylaxis, diuretics can be considered. Here at the University of Iowa, we preemptively obtain a chest radiograph 6 to 8 hours after closure in order to try to pick up early pulmonary edema and adjust the ventilator settings as needed. We also provide specific blood pressure targets, not just for hypotension, but also careful observation of increases in blood pressure from the baseline. Even if the baby is not reaching traditional hypertension targets, there may be enough change in afterload, which could precipitate a higher risk for LV diastolic dysfunction with pulmonary hypertension and secondary pulmonary edema. I hope that this was helpful. I would like to thank my colleagues here at the Iowa Hemodynamics Program and the NICU for their ongoing passion and collaboration in looking after our little babies, and I welcome any questions that you guys may have. Thank you very much.
Thank you, Adrian, for your broad coverage on this topic, from physiology to outcomes to giving our attendees some kind of good tips on how to manage these babies. So it is my pleasure to introduce our next speaker. Our next speaker is Dr. Jeff Rees, who is a neonatologist and a professor in pediatrics at the Vanderbilt University in Nashville. And his work in basic science has contributed to our understanding of the biology of the PDA. So I'm going to introduce and hand over to Dr. Rees.
Okay, thank you, Poorva. Hopefully my slides are there. It's an honor to be part of this conference and to learn something every few minutes. I need to pay more close attention to things that are happening in the nursery and less attention to things that are happening in the laboratory. So I think I'm going to be the one asking all the questions in the question session. So on the topic of basic biology of PDA, a challenging topic to cover in 20 minutes, I decided to cover just two main topics. I always start my biology talks on reminding the audience that we've known about the ductus for a long time. In fact, the ancient anatomist Galen of Pergamon was known to have recognized what the ductus was in some of his anatomic dissections. In fact, this is a woodcut from the 1600s of Galen performing a vivisection on probably a wild boar. And it was known from the ancient days that you weren't allowed to dissect humans or do autopsies or necropsies. And so most of the anatomic descriptions of the vasculature that were known until the 1500s were primarily done on large animal models. One of his early writings, once translated, showed that Galen described accurately how a shunt that sends blood, there was a shunt that sends blood from the pulmonary artery directly into the aorta, bypassing the fetal lung. So we've known about this vessel for actually 2 millennia. In medical school, we teach that the formation of the aortic arches occurs in parallel with formation of the heart. This diagram shows that the heart development begins as a fusion of paired tubes. You can see that the fused tubes here at an early point in gestation give rise to dual aortic branches that are separated by an outpouching of the foregut. And just a few days later, the fused tubes are beginning to loop and form a single outflow tract that gives rise to these aortic arches or pharyngeal arch arteries that we recognize as the precursor to the ductus. And if you look in this video of a fused heart tubes that are giving rise to this atrioventricular canal, you can see that as looping takes place, the upper portion rotates down to become ventricle, the lower portion rotates up to become atria, and the outflow tract is beginning to septate and give rise to these aortic arch arteries. An aortic arch formation occurs in staged fashion, with the first, second, and third arches being formed earliest, and the fifth and sixth arches not being formed yet. And as they form, the first and second arches begin to remodel into other portions of the cardiac outflow tract and perfusing vessels to the brain and upper body structures. And you can see now the sixth arch has begun to form. A fifth arch doesn't truly exist in higher mammals, but is shown for diagrammatic purposes from lower animals that these studies were done on. And this pictograph just shows that the sixth arch is formed from this plexus that is occurring lower off of the main aorta, the dorsal aorta, which has now become a fused structure. This is a EM cast or an EM image showing that the first arch is regressing as the sixth arch is forming. And here you see the dorsal aorta has fused into a single vessel. The structures of these pharyngeal arch arteries remind us of gill arch arteries in fishes and aquatic mammals. And the same body plan exists where a paired tubes form a heart which beats into a conotruncal outflow tract and gives rise to gill arches. Those gill arches have a recipient gill arch on the other side, and gas exchange takes place by allowing water to flow across this high surface area. The gill arches then return to a paired dorsal aorta that then fuse into a single vessel. So that body plan exists all the way through our ancestors. And you can see in this diagram here, the heart would be connected at this point, the descending aorta connected at this point. You can see that as the heart begins to remodel and the ductus forms, that you can lose precursor vessels here that become other vessels, eventually forming the final ductus arteriosus and eventually the ligamentum arteriosum, which the ductus remodels into. A ductus-like structure is known to be a common ancestral vascular apparatus in all of our vertebrate ancestors. The gill arches I've previously described are shown here. There's an animal called the adult lungfish, or a lungfish, which in its adult form lives both aquatically and on land. And it has a ductus that reversibly opens and closes depending on which environment the fish finds itself in. So when it uses its fins to crawl up on land, then the ductus reversibly closes and can reopen when it becomes aquatic again. Amphibians in their tadpole stage have an open ductus that closes when they become an adult amphibian. Some reptiles have the same thing. Birds have a ductus. In some cases, common birds like the chicken have bilaterally paired ducti that persist. And in higher order mammals, we all have the ductus as we know it. In fact, if you look close enough, you can see that there's a ductus in almost every animal that's ever been studied, including in these examples by Ed Zielinski, higher order mammals, birds. No matter how complex or not complex your heart is, you still have a ductus. Crocodilians and non-crocodilian reptiles. So the ductus has been around a long time. The ductus exists in many different life forms, and it all starts as an open vessel, and for the most part, it all starts as a closed vessel. So one of the overarching questions that has been posed over time is, what is it that makes that vessel so different than all the other vessels surrounding it? How does a ductus become a ductus other than being derived from the left sixth aortic arch? And what are the biological characteristics of things that make it different, and can we use that to our advantage? The advantages of knowing that information are somewhat obvious. If we knew what makes the ductus different than surrounding vessels at a gene or protein level, then it might be possible to design ductus selective therapies. For example, a gene or protein that exists only in the ductus and nowhere else. You could imagine devising drugs to target the vessel just by the sheer nature of the fact that the gene or protein is only expressed there. We could also use ductus targeted therapy. So even if you can't find a gene or protein of interest in the vessel itself. If you could find it on the endothelium and it's selective to that vessel, then you could send drugs there that are microencapsulated in a vesicle or a liposome or some other structure, a nanoparticle, to direct your therapies to the ductus. And finally, if we knew what made the ductus different than other vessels at a genetic standpoint, we may be able to screen for patients that are more predisposed to responding or more predisposed to failing medical treatments, or we could design personalized treatments or pharmacogenetically approach this problem by looking at which babies carry a variant that would make them susceptible or receptive. So what are the things along the lines of this question now, what makes the ductus so different? I'm going to go through a few points that may be biologically important for us to think about. The first is that the ductus, the other contribution to the ductus that we don't think about often is the migration of neural crest cells. So there's a subpopulation of cardiac neural crest and migrating neural crest cells that transit through the 4th and 6th aortic arches. And in some cases, they probably also go through the 3rd arch. And you can see in this diagram, the 1st and 2nd arches are starting to remodel into other structures, and they don't receive a neural crest component. But these neural crest cells differentiate from a neural fate and become the precursors of smooth muscle cells, which populate the conotruncal outflow tract. So the truncus arteriosus here divides over time and becomes the aorta and pulmonary artery, and that aorta could, that conotruncal septum is partly formed by migratory neural crest cells. You can see in this next panel that the more definitive adult pattern happens by around 7 weeks, and the ductus arteriosus here is the remnant of the left 6th aortic arch. You can see the arches precursors numbered for internal carotid, external carotid, and various other arteries in the head and neck. But the ductus arteriosus has its own precursor vessel, and it's made up of migrating neural crest cells. Researchers have actually started to exploit that knowledge, and they've looked at neural crest cell markers either with a fluorescent tag like Trish Lebowski showed in this upper image, or with a LAC-Z promoter as shown in the lower image. So starting in around the mid-2000s, investigators have mapped the fate of these neural crest-derived smooth muscle cells. You can see there's a very fine, sharp demarcation line where crest-derived smooth muscle cells populate the ascending aorta, the transverse aorta, and the ductus arteriosus, as well as parts of the carotid arteries. And there's a very clean demarcation line in the right subclavian, as well as this transverse mark here, where smooth muscle cells that are derived from crest populate. And we originally thought that this may be one of the reasons that neural crest cells help differentiate the ductus from other vessels around it. In studies that I'm not going to show, but studies that have been done, we showed that despite the fact that the ascending aorta and ductus have a shared crest origin, that doesn't account for the difference in smooth muscle reactivity between these two vessels. So even though this is a distinguishing feature, it's probably not one that will help us physiologically. The other thing that may distinguish the ductus is the presence of Vasovasorum. So if you recall from med school, large muscular arteries have their own arterial blood supply that's called the Vasovasorum. So if you're a large, thick-walled muscular artery, you need to have a blood supply of your own to supply the muscular media and keep it healthy during your lifespan. And those Vasovasorum, as they're called, run over the surface of the adventitia. They also course through the tunica media, or the muscular coat, and penetrate from the tunica intima as well. So in these diagrams, you can see Vasovasorum run over the surface. The origins of Vasovasora come from the actual lumen of a large muscular artery, and they feed back a network of vessels to themselves to keep that muscle wall healthy. And in states of unhealth, like atherosclerosis, we can see that there's chronic hypoxia or inflammation that drive overgrowth of Vasovasorum into the wall of a damaged vessel. So Vasovasorum may be a distinguishing feature of the ductus arteriosus since it's a large muscular artery. And Ron Kleinman brought this to our attention clinically when he published a paper in 2002 thinking about Vasovasorum in the ductus as a possible reason for why maternal indomethacin, when given as a tocolytic during pregnancy, gives rise to babies who don't close their ductus very well. So we all know that indomethacin crosses the placenta and can cause ductus closure. but that doesn't happen as often at less than 32 or 32 weeks. One of the reasons may be that babies less than 30 weeks have less penetrating vasovasorum, as shown in this diagram on the right. Vasovasorum are stained with an endothelial marker, and it shows that they're really limited to the adventitia in preterm babies. But if you look at a cross-section of a human 37-week ductus, you can see that there's penetrating vessels from the adventitial surface about a third of the way or 2/3 of the way in. And these vessels help support the health of the muscular area. And between diffusion from a luminal gradient and feeding from the adventitial surface by vasovasorum, that muscular coat is kept healthy. However, theory is when a mother takes indomethacin after 32 weeks and forces constriction of the vessel, then you pinch off this blood supply and you create zones of ischemia, shown here with an ischemic tissue marker that lights up with a BF5 that lights up fluorescently. So the inner media around the lumen is not ischemic because it's fed by diffusion. The outer layers are fed by vasovasorum, but you can pinch off the blood supply and create zones of ischemia in this ductus wall, giving rise to the theory that in fetuses and newborns at term gestation, these penetrating vessels can predispose to ischemic damage, but preterm ductus, which lacks those penetrating vessels but is thin-walled, they don't need that perfusion, that kind of perfusion, and so indomethacin doesn't create a PDA when mothers are treated in an earlier gestation. We like that theory, and we tested it in mice, and we about the same time that Ron Kleiman was reporting this, but what we didn't find was vasovasorum surrounding the ductus. So this is a vascular cast of the Ductus Arteriosus of a mouse. This is the ascending aorta with its coronary branches. You can see the fine casting material entered the pulmonary vascular bed, but didn't show any vasovasorum. In cross-section, we also used two methods to stain for endothelium and found that the ductus lumen was brightly lit up by a Laxi reporter or by immunostaining, but there were no penetrating vessels or vasovasorum on the surface like we would expect. We then have come into agreement then that there's probably some other mechanism by which indomethacin causes the PDA after a mother has prolonged indomethacin in the days that we gave it frequently for tocolysis. And it's partly due to ischemia of that zone of vulnerability in the muscle wall, but the same thing happens in mice. If you give them prolonged indomethacin or COX-1 and COX-2 inhibitors, you get offspring who have a PDA, and they don't have vasovasorum. So we think that there's a second mechanism whereby the presence of prostaglandins during gestation helps the ductus know how to be a ductus. So it's a developmental programming step that we're still working on. So it's not clear that vasovasorum are necessarily the thing that makes the ductus different than all other vessels around it. The concept of precocious maturation came up in the 1980s from Adriana Gittenberger to Groot's lab. And thereafter, there's been some identification of various different genes or proteins that distinguish the ductus from surrounding vessels. In this example I show on the left, the SM1 isoform of smooth muscle myosin is expressed everywhere in the vasculature, but the SM2 heavy chain myosin isoform is really restricted to the ductus. And this evidence in a different cross-section here shows heavy immunostaining for the SM2 isoform in the ductus wall before it shows up anywhere else. Other investigators have found similar results for desmin or tenacin C and several other muscle markers showing that there's precocious maturation of smooth muscle markers, not necessarily elastin or other markers that may be things that distinguish the ductus. And this really revolutionized the field to start thinking about individual molecules that could be found that make the ductus different than vessels around it. I was struck by this paper in the 1990s by Jeff Robbins' lab in Cincinnati that showed in his studies, they were studying retinoic acid signaling in developing mice, and they hooked up a Laxi reporter to the RAR beta, retinoic acid receptor beta, vitamin A receptor, and thinking that it was going to light up different parts of the myocardium at different stages of gestation. What they consistently kept finding was that it lit up very strongly the ductus seen at term gestation, term fetal gestation here in cross-section and in a longitudinal superficial view. This is the ductus connecting the pulmonary trunk to the aorta. And in cross-section in a preterm mouse, you can see the ductus lights up very cleanly compared to surrounding tissues in longitudinal and cross-section. So this was another example that came on early that there may be ductus-specific or ductus-selective expression of different genes. This data shows the similar result for the PAX3 gene, although it's not selective to the ductus alone. It's the outflow tract, similar to that neural crest marker. And this, more interestingly, published in 1987, was the prostaglandin E receptor called EP4. There's 3 different prostaglandin E receptors, and the EP4 receptor is highly localized in the vessel wall, shown here in cross-section in Bev Kohler's paper, and here in longitudinal section and data from our laboratory. And this was notable because that paper in 1997 also was the first example of a mouse model of PDA. When you knock out the EP4 receptor, you get a mouse whose ductus can't close, and those pups, those offspring, die within the first 24 hours of life. So this gives us the idea that there probably are a subset of genes that are restricted to the ductus, and that set in motion a scramble for about 2 decades to try to define the ductus genetically or from a protein standpoint, and how this vessel is so different than all other vessels around it. And what we're left with, just in this review table that was put together by Elaine Shelton, a colleague at Vanderbilt who thinks about the ductus, is this table of candidate genes or candidate drug targets, and they are gleaned from different expression studies or candidate gene studies or microarray studies, which I'll move to next. But she categorized them. I know you can't see this, but I'm just going to point out that these are genes that are enriched in the ductus. These are mouse models of PDA, human syndromes that have PDA, and single nucleotide polymorphism or genetic variants that correlate with PDA. And what she did next was to organize these into a nice diagram that really lists about the same number of, about 60, 65 different favorite genes that PDA researchers think about, that are either enriched in the ductus by gene expression or protein localization studies, or they're linked to ductus or PDA function, either in mice or animals, and the sweet spot in the middle, which she identified as the druggable genome. So the druggable genome is an interesting thing for drug developing scientists to think about. They've identified around 4,000 to 5,000 different ion channels, enzymes, G protein coupled receptors, for example, as genes or proteins that would make good drug targets. And there's plenty of pharmaceutical companies out there making compounds to try to inhibit any of these things that are within the druggable genome. Rather than being a structural protein, these are functional proteins that might make for a good medical target. So there are some gene or DA selective candidates within the druggable genome already. So how is it that you get to lists of candidate genes or proteins like that? So here's an example of work that we did with Elaine that shows efforts to discover the transcriptional profile of to identify ductus-specific gene sets that might regulate vascular tone. And what you do in these experiments is to cut out the Ductus Arteriosus. This is a mouse, a fetal mouse at term gestation that we've injected with blue dye stained agarose, so the vessels stay distended, just to show that we can cleanly dissect the ductus away from all the other tissues around it. Then you extract the RNA from that tissue and wash the RNA over a microarray gene chip, and it forms hybrids when it's labeled fluorescently with anchored transcripts that are on this chip, and they glow brightly wherever there's a match. And so you can come up with a expression profile of all the genes that are expressed in that tissue at that time. And if you then take all of those RNAs from the ductus and you take a similar size sample of ascending aortic arch, again, we used ascending arch because they're both derived from this glowing smooth muscle, neural crest derived smooth muscle. So we take identical size pieces of vessel, extract their RNA, extract the RNA and hand it to the microarray chip. And the computer analyzes that data, and it doesn't know which sample came from which tissue, but we do. And it assembles like samples with like samples and forms a dendrogram that shows you how they're related. We happen to know that this one was the ductus and this one was the aorta, but the computer didn't know. So this is an agnostic way to let the computer decide what tissues are like each other, and giving us the identity of genes that are strongly expressed in one but not the other. A second way to do this is to perform a principal component analysis, which shows that ductus tissue is not at all like the aortic sample tissues. And the outcome of these type of studies gives you nice, hopefully manageable lists of genes that you can do your next series of studies are to find out if these are genes of interest or genes that can be targeted. So we obviously weren't the first ones to think of that, and we aren't the last. By now, there's about a dozen different microarray or gene expression profiling studies on the ductus. An enterprising grad student in the lab has taken this opportunity during COVID to kind of put data together to look at all the different studies. We identified 9 studies at that time. And I drew a red line to show you that the studies above the red line were ones that compared ductus to aorta. We think that's the best way to control for gene expression over time, rather than comparing knockout to wild type or a drug treatment to another treatment. So if we take the data from these 4 studies and ask the question of all their upregulated genes, are there genes in common among all these 4 different studies? And what Michael found when comparing those 4 different studies, there was only 41 genes that were uniquely common and upregulated in those subsets. So that's exciting, but that's also really probably too small a number. We felt like we'd be missing important genes. So we loosened the criteria to accept gene candidates that were differentially expressed genes in at least 3 of the 4 studies, and found 276 genes that were significantly different in all those studies that were common between them. So that is a good gene list for somebody like our group to work on. At the same time, we also came into the opportunity to evaluate human ductus specimens from a prior study that had been performed. And the gene expression analysis in a more modern era is usually done by RNA-seq or single-cell-seq. And in our case, this study was this human DA samples were analyzed by RNA-seq. The data came to us for analysis. And we had 4 individuals that had paired ductus and aortic samples that from pre-viable pregnancies that we could analyze the gene expression of again. And you can see that the computer easily could aggregate data from ascending aorta and ductus arteriosus, and they were differentially expressed to a large degree. And when you look at that human RNA-seq data with a plot called a volcano plot, we ended up finding around 180 different genes that were differentially expressed between ductus and aorta. And in our efforts to compare what we found in human, we got all excited to figure out which ones are the same in mouse and human. What we found was that of the 186 differentially expressed genes in human by RNA-seq, and the 270 in rodents, this is rat and mice, by microarray, there were only 11 in common. Reassuringly, of those 11 were genes that we always find in all of the array studies, this transcription factor AP2 beta, this PGE receptor called EP4, and ABCC9 is a potassium channel gene that's abnormally regulated in Cantu syndrome. Cantu syndrome patients have a large incidence of PDA, so these were reassuring findings. And we were a little surprised that we were able to find this many, actually, because this is human versus rodent studies. This is RNA-seq versus microarray. This is pre-viable term pregnancies, and these are late preterm or term rodent arrays. So despite the fact there were so many cross-platform and cross-species comparisons, we thought it was terrific that we got that many things in common. When you do studies like this, you end up with a long set of genes that give your lab lots of work to do for the next few years of your life. And this table was an appendix to Michael's study, but it just shows that in green are all the genes, the 41 genes that were found by all 4 different studies in common. And so this forms a nice list of genes that we want to work on. Everything below the line is the 3 out of the 4 comparisons. We did the same thing for the human data, and we looked at genes that were upregulated in ductus versus aorta. And some of our friends are there. The PTER4 EP4 receptor is there. It's 20-fold upregulated in the ductus versus the aorta. And there are several other candidates of interest. All of the things in this list are things that we hope to pursue in the future. And when you get array data like this, it needs to be confirmed by protein and other studies. And in some cases, we get the occasional human ductus that comes along from a patient who's had congenital heart disease, like hypoplastic left heart syndrome, and needs to have their ductus taken out. We now have IRB approval to collect that sample and do stains on it or cytochemistry. And in this case, this shows the strong expression of this transcription factor AP2 beta that's strongly upregulated in the ductus of mice and humans. And you can see that in green that it's well expressed in the muscular coat of the ductus arteriosus. So we aren't the only ones who are interested in, sorry about my slide advance. We aren't the only ones interested in this. There have been many other opportunities or chances taken by investigators to try and get unique information out of the human ductus arteriosus. All studies on the human ductus are somewhat troubled by the fact that you can't just go to the nursery and get a sample. You have to wait for a pre-viable specimen or a specimen for an autopsy in a child who died from other causes, or a ductus from surgeries for congenital heart disease. And so babies with congenital heart disease don't frequently present untreated. They usually are several days or weeks old and are maintained on a prostaglandin infusion. So all of the human studies to date are usually plagued with some kind of shortcoming based on the availability of tissue specimens. But this paper by Ron Kleiman, John Daigle, and our combined groups showed that with advancing gestation, we could pick out from a list of 48 different candidate genes. We could monitor changes in transcription over time. We identified this prostaglandin transporter gene and the eNOS gene as two candidate genes of interest that are regulated in an interesting way and possibly serve as candidates for treatment. A similar paper by David Dean and his group looked at 18 different candidate genes. In this case, their samples were taken from patients that have coarctation. So again, somewhat suspect of how representative this tissue would be of native ductus, but still they found the genes of interest that we have found in the past, along with several other interesting genes. Probably the first effort to look at transcriptomics of the human ductus was done in 2009 by this group. Unfortunately, you can see that the candidate genes that they looked at were babies that had stents put in their ductus and were 200 days old, or 147-day-old closed ductus, or a 1-day-old open ductus. So these studies are just a little bit hard to interpret as to what they mean for the native fetal ductus or neonatal ductus that we face. This most recent study by Yokoyama's group in Japan looked at babies with complex congenital heart disease, including coarcs and other complex diseases, and the youngest of their patients was 17 days old and out to almost 100 days. So these all give us interesting bits of information that form parts of the puzzle. We're just not sure what to do with all the pieces of the puzzle yet. Most recently, what we've done in our laboratory is to go back and look at all the different mouse models of PDA. So I kind of jumped ahead and started talking about animal models without introducing that very well. But people have used piglets and newborn lambs, guinea pigs, rabbits, many different other models to study the physiology of the ductus. We happened to start studying the mouse model, the PDA, because we were one of the first groups to find a phenotype when the COX-1, COX-2 genes were knocked out. We found a mouse model of PDA. So this is data from our competitor's lab that showed a nice wide open ductus. This is the very first knockout PDA that I mentioned in the EP4 knockout mouse. And there's 28 different mouse gene knockout models that when you remove that gene and that gene alone from the transcriptome, you get a mouse with a PDA. Some of those PDAs are transient, like the myosin heavy chain 11 knockout mouse goes on to survive once they manage to get their ductus closed. Some of these ductuses are small, fairly small in size, and the animals can live long. But if they're born with a large PDA, like most of these animal models are, they usually die in mice within the first 12 to 24 hours of life. So when we published this paper a few months ago, there were 28 knockout models of PDA. I think there's probably going to be another 2 papers published before Christmas, so this number is up to 30. At the same time, we wanted to know, how do these animal models, how do these very significant genes in ductus regulation compare to human? So one way to do that is just to use our human genetic databases like OMIM and other databases and ask which genetic syndromes have a PDA, and specifically which human single gene syndromes have a PDA. And if you do that using OMIM and several other databases, you can pare the list down to about 224 different human single gene syndromes that feature PDA as a component. And when we use protein-protein interaction mapping for those 224 genes, we can see a nice network of genes that probably are coordinated and talking to each other sometime during development. So there's a red star in this diagram that you probably can't see, but around 12 of the 28 genes over here correlate with these 224 single gene syndromes, single gene mutated syndromes that have a PDA, making us think that we're probably going to be able to build a fairly complete genetic map of how all these genes work together to form a ductus and maybe help it maybe be dysregulated after birth. So the second part of my talk is shorter, but I want to draw attention to, rather than a global look at transcriptomics and biology of the ductus and how the ductus forms, I want to look at something a little bit more practical, and that's the relationship of oxygen to ductus closing. And it's long been held that oxygen is a highly potent regulator of the ductus. In fact, it was in the 1820s, nearly 2 centuries ago, that the relationship of ductus closure with breathing and oxygen return was first noted in the literature. So almost 200 years exactly ago, we learned that oxygen has an effect on closing the ductus. This is really around Joseph Priestley times when we were learning about what oxygen was and then it could have signaling effects. A short time later, we know it was reported that ductus closure requires actual breathing in animal models. We've since learned that oxygen is the most potent and effective constrictor of the ductus. Unfortunately, no true oxygen sensor has really been able to be identified. So here's data that came out of studies. There was a clinical group at Vanderbilt led by Amos Christie in the 1930s who studied the ductus. I think they drew the attention of several other biochemical investigators, Kennedy and Clark, who published extensively on cardiopulmonary issues at Vanderbilt. And in 1942, they reported the effects of oxygen in closing the ductus using vascular casting models and various different animal models. This data from 1950s showed that sheep that were pregnant sheep that were ventilated with either air or oxygen had a constrictive effect on the fetal ductus that was reversible. This was by cannulation of the fetal ductus and measuring, either measuring its external diameter at autopsy or with other physiologic measurements that were performed around that time. But finally, this review by Ken Weir and Stephen Archer and their colleagues have kind of painted a more clear picture of how oxygen affects the ductus. It's really not totally clear. The oxygen clearly affects the coronary arteries, the pulmonary vasculature system. So they've created a different schema for how these different components interact with oxygen to affect smooth muscle closure or relaxation. And as you can see by the different arrows, it really starts with sensing in the mitochondria and emanation of some diffusible molecule that has an effect on redox control. There's several kind of different black boxes in this diagram that are still unresolved, but the idea that mitochondria signal to a redox center and then affect the change through calcium or potassium channels is held up over time. So when we think about the mechanisms of ductus regulation by O2, there's really three different camps of thought on how this could take place. And I'll just show you briefly results from 3 different arguments on how that would be possible, and then we'll close. Flavio Cocciani was a Canadian investigator who's moved back to Pisa and continued his studies. And Peter Ollie and Flavio Cocciani were mentioned in Suvik's earlier talk as being the people that made the earliest observations on prostaglandins and prostaglandin inhibitors having an effect on the ductus. And modern neonatology has been thankful to them ever since. But Flavio was always bothered by trying to figure out how oxygen played a role in controlling ductus closure or patency. And he hit upon the idea that there was a cytochrome P450 enzyme in the vasculature. These are the same enzymes that live in the hepatic microsomal enzyme system. But cytochrome enzymes are also known to exist in the vasculature, and they play a significant role. So he thought that the cytochrome P450 system in the vascular smooth muscle was probably acting as a sensor for oxygen and working by way of using endothelium as an effector. The second camp came from Stephen Archer, also a Canadian who's worked in the US and is now back in Canada, along with colleagues Weir, Cornfield, Thibault, and many others who have signed on to this theory, who believe that the mitochondria is probably the place where sensing of oxygen changes take place. They give off a redox signal that is then has an effect on either potassium channels or other end effectors. And their more recent data has provided interesting information on mitochondrial fusion as a component of this as well. And then data from several different labs, Jack Roberts at Vanderbilt, Eduardo Villamor, our laboratory, and Dr. Blancourt, have shown that isoprostanes, things that we think of as typical markers for oxidant injury may actually have a physiologic role or a pathophysiologic role in regulating the ductus, and I'll touch on that last. So just as an example of what Flavio Cocciani has published over about a 3-decade effort to show that this is true, is here's an example of immunostaining of the cytochrome, in this case 3A corollary called cytochrome 3A13. You can see it's clearly localized into the muscular wall of the ductus of, I think in this case is a sheep. No, maybe a mouse. This is the mouse. And this diagram on the bottom shows if you take a mouse ductus out and mount it on rings and measure its tension, then a wild type mouse that's exposed to 30% oxygen increases its tension over time. But a CYP3A knockout mouse doesn't necessarily increase its tension, but it responds to oxygen with increasing oxygen content in a similar way. It just does it in a spurting way. This is not vasomotion as we heard about earlier. This is something different. So it has an ineffective response to oxygen, but it does raise its tension over time. Interestingly, this CYP3A knockout mouse doesn't die with the PDA. It just has abnormal oxygen responsiveness to the PDA. So this one figure that Dr. Cocciani put together in a review in 2012 actually summarizes about 3 decades of work. The first part of the table just reinforces that there is cytochrome P450 mechanism as judged by many different experiments and many different perturbations to try and show that this contributes as an oxygen sensor in the vasculature, specifically in the ductus. The lower half of the table also points out their own data and other people's data that endothelin-1 is a likely effector of oxygen sensing in the ductus. Finally, another convincing argument that I liked was when they took mouse aortic smooth muscle cells and cultured them in a dish and genetically transferred the cytochrome P450 of interest into those cells so that they now have a cytochrome P450 3A13 function. Those aortic cells which were not responsive to oxygen became responsive to oxygen like the ductus. So I found that to be a fairly convincing argument in addition to his other work. The second theory that I mentioned by Stephen Archer and multiple others was that mitochondria acted as a sensor. And there's so much data, it's just hard to put all into one summary slide. So I used a summary slide from somebody else. It shows that with an increasing oxygen tension, that the mitochondria, different steps in mitochondrial oxidation, release some diffusible signal, probably hydrogen peroxide. Hydrogen peroxide concentrations are released into the cytosol where they act on various different effectors. In this diagram, it's a potassium-gated, a voltage-gated potassium channel, which changes the electrical potential across the membrane, activating L-type calcium channels. There is also release of calcium from intracellular and transmembrane stores by other mechanisms, with a resulting surge in intracellular calcium, which triggers myosin light chain kinase and myosin light chain to become cross-linked and work with actin to affect ductus contraction, and ROC help reinforce calcium sensitization and sustained contraction of these smooth muscle cells. In addition, more recent data from Dr. Archer and colleagues focuses on the mitochondrial cycle of biogenesis, fusion, and fused mitochondria undergoing fission in collaboration with the endoplasmic reticulum, proteins related to this process, including DRP1. And what they've shown is that mitochondrial dynamics happen very quickly within cells. This is work of the Archer Lab and others, but mitochondria, when labeled, quickly make contact with other mitochondria and spread their contents and spread signaling, and the act of fission and fusion happens very rapidly in cells, even non-dividing cells, while they're, and oxygen is probably part of interacting with the fission fusion cycles and releasing agents that help control ductus tone. Finally, the work from Jack Roberts and our lab at Vanderbilt, as well as Eduardo Villamor, shows, just as an example in this figure from one of Jack Roberts' papers, when you're born as a term-healthy newborn and go from a fetal oxygen environment to a newborn oxygen environment, you have a burst in isoprostanes that takes place. That takes, in some cases, weeks or even months to return to the normal adult baseline values. So the idea that there's a surge in isoprostanes at birth, and that isoprostanes work in a signaling fashion, not just in a toxic fashion to the cell, gave us the idea that it could be that breathing oxygen at birth helps constrict the ductus for other reasons than the cytochrome P450 or mitochondrial redox mechanisms. It could be through this isoprostane pathway. So we took newborn mice, exposed them acutely to room air or to 80% oxygen at birth, and within 4 hours showed that there was increasing amounts of isoprostanes in serum in those animals. And if you take the ductus out of newborn or fetal mice and mount it on glass pipette tips and watch it close over time or watch it close in animals, you can see that there's an effect of these isoprostanes. For example, this is a tracing showing a mounted ductus arteriosus of a term mouse exposed to KCl to make it constrict twice just to make sure it's a good preparation. And then we washed everything off, and at baseline conditions gave it increasing concentrations of 8-iso-PGF2 alpha, and showed that with each increasing dose, the vessel constricted in a gradual way to the point where it was almost as close as tight as KCl. So this data showed that in term mice, isoprostanes acted as a constrictor. Data that I'm not going to show you showed that in preterm mice, some of those isoprostanes can also act as a vasodilator. So this summary slide from Eduardo Villamor attempts to place the reactive oxygen species molecule in the center of a very busy pathway that includes all of those other markers. So I'll finish with 2 slides showing that there's maybe a way to take advantage of these findings. So that this most recent paper by Stephen Archer's group, where he did a whole genome assessment of what happens when you expose human ductus smooth muscle cells to oxygen, he found big networks of genes that are related to the mitochondrial protein complex and the mitochondrial matrix. This is a small sampling of the data they showed, but it gives us the idea that there's many possible pharmacologic targets there. The other thing that has been shown that I'll finish with is that you can transfer potassium channels, or things that make you think the ductus are different than other vessels, like this potassium channel. You can transfer it into the ductus of a preterm rabbit or a human ductus arteriosus and make it more strongly respond. Lane Shelton has done the same thing pharmacologically by mounting a mouse ductus, in this case a preterm ductus, and shows that it's a living vessel by making it constrict with potassium, but it doesn't respond very well to normal oxygen concentrations. But when you pre-incubate it with glibenclamide to act on those potassium ATP channels that the Cantu syndrome patients have, you make it suddenly much more oxygen sensitive. And when you compare that to the knockout of that gene, which makes it exquisitely sensitive, you can see that pharmacologically we may be able to find drugs that not force the ductus to close, but just make the ductus more sensitive to oxygen. So these 2 summary figures came from Dutch investigators in 2010 by Regina Bokenkamp, showing that there are many complex pathways that interact in the ductus. And our simple idea is that we're going to find one key molecule or one key pathway, may be oversimplistic, but that doesn't dampen the challenge of trying to find those pathways. And again, Tim Hunscheid and Willem de Boot have shown that the timing of when you look for those pathways is very sensitive, because the drugs that you expect to work on the ductus have a temporal specificity as well. So I'll close with those comments and hope that I've left room for time for some questions. So thank you very much.
Thank you very much, Jeff. I want to thank you and, of course, all the speakers. I think the topics today were really, they feel like at the forefront of medicine and research for NICU care, for all how we care for our preterm babies with PDA. I'm grateful for all the panelists here. They've made themselves available for a Q&A session, which may be a little bit more abbreviated than we had hoped, but we'll try and initially to direct at least one question to each speaker. So I'll kick it off with a question from Tim Hunscheid to Patrick. And this relates to Fief El-Kafash's recently published, I guess Nadine Boosman in the Journal of Perinatology had a comparison of the risk of BPD in that RCT. It was a comparison amongst the babies in the intervention group who received targeted treatment versus those in the control group, but substratified according to response to therapy. And in that trial, Tim notes that the rate of BPD in the unsuccessful group, so the babies who received ibuprofen but whose PDA did not close, was 85%, compared to the rate of BPD in the control group was 60%. And he's asking could there be a risk of giving ibuprofen, as noted in animal studies, through an inhibition of angiogenesis, such that if the PDA closes and this risk is overcome, then that's good. But if the ibuprofen is not successful in achieving PDA closure, might that actually be deleterious to the baby by increasing the risk of BPD?
Thanks, Dany. Yeah, I've seen Tim's question. I think it's certainly interesting, and again, we're first, I want to say is we're talking with very small numbers. I think that's the first thing. This is a signal, but within the answer to the question, I think there are two comments I want to make. So the first is a philosophical one, which is ensuring that therapies are likely to work for the indication you want to use them is really important, because I think I showed a slide on day one that if you have a high degree of enhanced diagnostic precision, the balance is likely to weigh towards efficacy. But if you're giving something that is less likely to be helpful, the balance will weigh heavily towards kind of adverse consequences. And yes, there are some theoretical biological concerns that drugs like not just ibuprofen, but also indomethacin may have other kind of effects that may be problematic. In looking at the actual data from kind of a FEAST study, the other important consideration was that within the failed group, two other factors are worth noting. One, the shunts that were less likely to respond were the most pathological shunts. So the indices of PDA score were actually higher in those patients. And secondly, kind of up to 50% of those non-responders to ibuprofen ultimately ended up needing PDA closure, and their duration of exposure to shunt was, I think, a median of 51 days. So you've got two hypotheses. One, perhaps an adverse effect of therapy, but the alternative hypothesis is that those babies were a signal for a higher group of infants at greater risk of, prolonged exposure and need for definitive surgery, which is similar to your work also, Dany. It's unmasking just a higher risk group of patients. But I think what I take out of this, and we try to apply this in practice, whether it's Tylenol, whether it's indomethacin, if you give a course of therapy and it has had no effect, move on to something else. Keep repeating the same thing with the same therapy. One is then likely to bias towards adverse effective therapy.
Thank you. The next question from our attendees is for Shovik. Could you comment on feeding while PDA therapy with indomethacin or ibuprofen? And I could even add their acetaminophen even.
We don't use indomethacin, so no problems there. With ibuprofen, there has been a lot of debate on, especially with the increase in use of oral ibuprofen. There has been lots of talks about whether to feed, when to feed. So what we do at our center, again, people might vary their practices, is if we have started feeding, we don't stop. We don't increase our feeds while we are treating with ibuprofen, but we don't stop feeds. And for oral ibuprofen, we would prefer to use oral ibuprofen, as I said, in any baby who is getting more than minimal enteral nutrition. So if the baby is on a feeding regimen where the baby is advancing feeds and the baby needs a duct closure, then we would prefer oral ibuprofen. But again, is that based on strong evidence? No. Have we seen any serious adverse effects? So far in our experience of using high-dose ibuprofen, we started in June 2017. So in the last 4 years, we haven't seen any difference in neck rates. And Poorva, for your question on acetaminophen, we are pretty relaxed with that. We just keep feeding. Most of the babies who get Tylenol are at a point where they're on full feeds anyway, so we would just carry on with feeding.
Great, thank you. I do have a question for Adrian. One of the attendee questions was, how about starting milrinone pre-cath, kind of before even monitoring for PLCS, and continue it for 24 to 48 hours?
I'm not sure of anyone who's doing pre-cath milrinone. We've always done it post-cath. I think the biggest debate is whether to do it targeted milrinone or to just milrinone for everyone. We tend to do it as a targeted approach by extrapolating the data from the surgical ligation data that was created in Toronto. And what we don't know is that if there are differences in the practices amongst the NICUs in terms of fluid management and other things that relate to the left ventricular output after 1 hour of the procedure, but also in regards to cath closure differences in terms of surgical ligation itself. So we are for now doing the same approach that we were for surgical ligation, and our duration of milrinone post closure depends on how the baby is doing. Typically is for about 24 hours, sometimes a little bit longer for the ones that are particularly hypertensive or who developed respiratory instability. Thank you.
Great, thanks, Adrian. Just a reminder for our audience, please do, if you can, put the questions in the Q&A rather than in the chat box. And next question is for Jeff. I know you answered this by typing, but I think it's worthwhile for the audience to hear. So if you don't mind answering for the rest of the audience as well. The question was, have you looked at a mitochondrial RNA expression from the lungs at the same time in order to evaluate whether there are some similar mitochondrial RNA that are differentially expressed in the lungs as opposed to cardiac or ductus?
Yeah, I think there's two questions there. I think they're asking about mitochondrial RNA, or they may be asking about miRNA, or regulatory RNAs. So the answer is there's not very many people working on regulatory RNAs in the ductus. That would be a good way to look at transcriptional regulation, but we don't even know the transcriptional targets yet. Mitochondrial RNAs are different in there's a small gene set that are in mitochondria that are being looked at by Stephen Archer, but I don't think that's probably going to be up or down regulation. That's probably going to be functional analysis. But the question was, do we compare those to the lungs? We don't really have the ability to dissect out newborn mouse distal lung vasculature, but my laboratory was immediately adjacent to the laboratories of Judy Ashner and Candace Fike when they were both here. And so we frequently had conversations about molecules that dilate the pulmonary bed probably are molecules that help constrict the ductus and vice versa. So we think about the pulmonary distal vasculature, and we try to scan the literature to compare our results to what the pulmonary hypertension people have seen. Things that regulate pulmonary hypertension would be interesting to us, but maybe in the opposite way. So we don't have the ability to do direct comparisons in a mouse because we just can't get the distal vasculature out like they can in sheep and pigs and other animals. So it's our way is indirect just by looking at the literature, what other people find.
Okay, thanks, Jeff. There is one, I think it is worthwhile for the audience. So Adrian, I know you're typing an answer there, but could you comment on the size of the babies you're currently offering for device closure using the Piccolo device? And what is the timing of it, as well as the criteria of failure of closure in order to go on to do device closure?
Thanks, Dany. Our criteria to indicate cath closure, first of all, the baby has to be above 700 grams, because that's what the FDA has approved for the Piccolo device, which is the device that we use for the preterm ductus. Most of our babies go for the cath lab after multiple courses of medical therapy that have failed or that they have contraindication. Because we do Tylenol primarily as our therapy in the first week of life, the majority of them got one course of Tylenol and then varied courses of either indomethacin or Tylenol. The majority of them get one course of Tylenol and 2 of Indo, or 2 of Tylenol and 1 of Indo, depending on their clinical course. And then like Patrick delineated on his talk, there's very comprehensive appraisal of shunt volume and significance in order to indicate the need for definitive closure.
Thank you, Patrick. You have your hand up.
Sorry, Dave. I was just going to add that like we have embraced the sub 700 gram, and Adrian is correct pointing out that this is the FDA. There recently, Sham Sathanandan reported kind of a small observation study of 18 infants under 700 grams. And actually, when you look at the meta-analysis from Adrian's study, there are babies that have had their PDA closed as small as 420 grams in Asia. So definitely the line is falling, but we have to be very, very cautious as we get under 700 grams.
Great, thank you. I think in the interest of time, we will just take one last question. So that question is for Shovik, and it's about rectal administration of, I guess, acetaminophen. What are your thoughts on it?
So regarding rectal, I think there has been a small retrospective study from Canada, from one of our colleagues out west, and they did find some improvement in outcomes, some reduction in PDA ligation. But obviously, we wouldn't at this point recommend it because there are no trials to definitively show that it carries the same benefit as you would get from enteral or IV. So I would look out for clinical trials, but I think there's some small observational data on it.
Okay, I would like to thank all of our esteemed panelists today for fantastic talks. As I said earlier, it really feels like this is the cutting edge and the frontier of PDA evaluation and treatment from the bench to the bedside. I'd like to, of course, thank everyone in the audience for taking the time this afternoon or evening, wherever you are in the world, to join us in our panel for this symposium. And I would kindly ask if everyone in the audience could please scan the QR code that you see on your screen, and please do fill out an evaluation. It certainly helps us for feedback as well as for creating future symposiums just like this. I'd like to also thank my co-moderator, Dr. Poorva Deshpande, for co-moderating the session. And thanks again to everyone. Have a wonderful day and evening.
Thank you, everyone.